Well, hi, everyone. This is Dr. Hillam, and this is our Entry Point podcast. And my intention in doing this is just to share the stories of our course attendees with you. I've been in implant education for over a decade now, and by far my favorite part about it is the people that I meet in doing this. And so I'm really excited tonight to introduce Selma Mohammedi. So, hi, Selma.
Hello, Dr. Hillam.
How are you tonight?
I'm very good, thank you. How about you?
The very same.
All right. Good to hear
Yeah,
that.
beautiful November evening, a little earlier for me here in Idaho, and a couple hours later for you in Vermont,
Okay.
right?
Yeah,
Newport, Vermont.
it's in Newport, Vermont, exactly.
I want to flash an image up onto the screen.
Yeah. Of Vermont?
Well, no, and I don't mean to surprise you, uh, Selma. It's just our recent live patient treatment course.
Oh,
Can you see it?
yeah, I see them. I received the pictures. They're lovely.
Oh, good. It was a nice weekend, wasn't it?
It was amazing. Literally.
So happy to hear you say that. And was the whole trip nice for you as far as just travel and lodging and
I
food and all
mean,
that?
yeah, everything was great. I was very surprised by Salt Lake City. Actually, pretty
Hmm.
impressed too. Yeah, it's
Hmm.
it's a nice city. I thought it was a lot smaller than what I saw.
Hmm.
And it's beautiful landscape as well.
Hmm.
So I would definitely would like to go back. Yeah.
The airport has been a Delta hub for as long as
Hmm.
I can remember. And I think that has helped the city quite a lot because anywhere in the West, if you're going to be in somewhere in California and you're going to go somewhere east of the Mississippi, it's pretty likely that you're going to go through Salt Lake City for a connector.
True.
So I think that's helped it. But it is getting bigger and it's kind of booming right now. But I'm really glad you enjoyed your time there. Let's see, this picture on the left is, I think this was on Saturday as well, but these smiles are real. So are the ones on the right.
Yeah.
Everybody, I think, was really happy with the experience they had at the course. And
And we got to meet and talk to each other because it was a smaller group. So we were able to
yeah,
bond more easily.
I think that's right. And of
Mm.
course, part of that, of course, maybe you could describe this. Could you describe kind of the didactic or classroom experience that we had prior to the surgery, before and after that? I think that'd be interesting for people to hear.
Yeah. So prior to the surgery, we received our cases so we can review the CBCT and the health history of the patient with the hot risks as well. And then we had to literally prepare surgeries. So we know what we're doing, what we're placing, what kind of implant we should place, with the bone thickness, all the different anatomy, how far is the nerve, the sinuses. So with the software, that was just amazing to be able to prepare the case on our own, basically. And once we got there, we were presenting our cases. So to our classmates, each of us did the same. Go on the computer and talk about the case and what we will do, what's our surgery. So it was great to see, obviously, others people's surgeries. What are they gonna place? And then they can see the same about us. So it just by reviewing and checking the treatment plans of different people, that's how we learn. Because the most difficult part of implantology is the treatment planning.
Isn't that the truth?
Yeah, yeah, definitely.
So
It's
there were the
interesting.
things that you learned from doing your case, presenting your cases, which was three patients. I think it was four implants across three patients.
Correct. Yeah.
Yeah. And there were the things you learned from that, but everybody else that was there did exactly the same thing. So you had the opportunity to see them open the case up in Blue Sky Plan and uh, go
Mhm.
through the same parameters that you just described: height, width, bone density, anatomical hazards, ridge topography, things of that nature.
Yes.
Uh, can you speak a little bit to? I remember you saying something that made me so happy when we met on Friday night, that you were pleased with the site-specific treatment planning course. I don't mean to be too promotional here, but I would really love to hear what you what you said about that, if you remember. I just the gist of it was that I remember you saying you're happy about that course.
Yeah, the site specific. Well, so if I talk a little bit about my background, I took a guided surgery class in Brazil. It was life patient, and I was just missing. I wanted to understand completely and to control completely my surgeries, and just not let other people prepare it for me and guide everything for me. So what was amazing, and we were able to that we know how to read a CBCT now, which is just amazing, and
Mhm,
then we can also do it on our own
mhm.
and place the implants on our own, and being very very confident about it because we planned it ourselves
Uh-huh. And then placing the implant in a free-handed manner.
in a free-handed manner. So I was a little skeptical about that. I
Mhm,
wasn't sure if the course was guided or freehand, and
mhm,
it turns out to be freehand. And I mean, it was a lot easier than I thought. A lot easier than I thought.
mhm.
Definitely,
Uh,
because
yeah.
it's kind of guided, halfway guided, because we do the work before, and then once we get there, we know what we're expecting: bone density, everything, basically, the height.
Yes. It's going to be fun to see your cases in just a few minutes too, because I think it'll be clear to anyone watching that they look like they were guided cases from start to finish anyway.
Exactly. Yeah, basically for all of us, even my partner, she placed a few implants too, and it was the same thing. So that's amazing.
Yes, and I'll probably restore several of these cases, and I'm going to see a screw access hole that comes right up through the center of the occlusal. I think on every case that we did or that was done, what was done? Maybe 25 implants were placed. It was probably less. It was probably 20, somewhere around there. I bet all of them. And that's not with a corrective angulation either, like with an angled screw channel. That's going to, they all looked that way.
Yeah, look
Uh,
that way.
yeah. I remember you saying that the site specific treatment planning course was what you were looking for. Am I putting words into your mouth, or do you remember saying that?
No, that's right. That's what I was looking for.
What did you mean by that? What were you looking for? Because you
I
had
was looking.
taken a guided course in Brazil, and that sounds, it was probably an awesome course.
It was awesome. It was really good, but I think it was good to open the door to implantology
Mhm,
and just to get more familiar with all the instruments, all the different parts of an implant.
mhm,
But like I said, like it's guided. It's like autopilot mode. You just do
mhm,
it, and that's how it is, and that's it.
mhm,
But now, if something goes wrong, you're not gonna be able to manage the surgery because you're just guiding. You're guided,
mhm,
basically, completely
mhm,
guided. But now, because we are able to understand the back scene of how we place the implants, why we're placing it like that, um, it's just a lot more easier and makes us a lot more confident. And that makes a huge difference. I'm approaching my different cases totally differently.
Are you? Have you had
Yes.
some that have come in front of you since the course, and
So
you're
yeah, I
seeing
had a
things
few
differently?
comments. I still do I'm still doing the guided with the it's like a concierge system. They a neurosurgeon or a prosthodontist will go over the surgery because I just want to compare because I did it myself and I want
Mhm,
to compare. And then when I'll find it's almost maybe it's going to be the same, then I won't need that anymore. Just do it on my own. Yeah.
I
So
see. So that's what's different, is that you're using a concierge service still, where you're getting the guide back. You're getting, I know 3Shape does that, for example, and maybe they're using 3Shape software, and they'll show bone density, bone engagement, and those things. But now you're comparing that to what you would personally do.
exactly comparing it. And just
Mhm.
because also I just recently took the course,
Mhm.
so I just want to compare
Mhm.
and then we'll just go freehand, especially
Mhm.
for some cases. I know freehand would be just the same as guided.
Mhm. Yeah, I think that's accurate. I think that's true in so many cases.
And
I
I
kind
was
of think,
also a little skeptical about the freehand. I thought it was more
yeah.
like it's just freehand. How is the
Mhm.
crown? How is it going to come out? Is it going to be well placed? Is it going to be
Mhm.
restorable the best way? You know what I'm saying?
Mhm.
But now I saw that yes, absolutely.
Yeah, is this still a restoratively driven process if you're
Mhm.
free-handed?
Yes, it is.
Yeah. And yes. Yeah, absolutely. I mean, there could certainly be such thing as a free-handed placement with an off-axis implant because it was only mobility that was considered, but that's that's not how good freehand is done. Good freehand is very
Yeah.
accurate,
And
you
it's
know?
like it's also different from freehand compared to other courses. I know some courses in South in Central America, they
Mhm.
will just use a panoramic X-ray and just do
Mhm.
freehand 20, 30 implants. But
Mhm.
at the end of the day, you just don't know what you're doing. You're just placing
Mhm.
implants, and that
Mhm.
doesn't bring you anywhere. But
Mhm.
now, like with this course, we really have all the science and technology behind it.
Mhm.
And we know that freehand, well, I placed only four, right? I feel
Mhm.
totally comfortable to go on my own freehand.
Mhm.
And I, during my Brazil, like my class in Brazil, some people took the whole course, placed 30 implants, and then took another course in Brazil because they didn't know how to place them after they have placed 30 implants on their previous course and spent thousands and thousands of dollars. I don't know if you understand what I mean.
I do, and I had somebody say this to me several months ago. He said, it was somewhere. I think it might have been Jamaica. And I like these courses. I like these high volume courses, and I've
Yeah,
taught at a
me
lot of
too.
them. I think they have value. But he said, you know, I did two ridge splits, and I placed, I think it was 12 implants or something like that. And he said, when I got back, my hands knew a little more,
Yeah.
but my
What about your brain?
brain hadn't caught up with what I did, and so I wasn't sure how to implement it when I got back into practice, you know?
Exactly. Yeah.
I thought that was pretty
It's a good
good.
analogy. Yeah.
Yeah, hey, you have to have both. So if your hands do get a little ahead of your brain in some of these courses, then you got to do something that catches your brain up to what you did, you know?
Yeah. So you catch up.
Yeah. I thought you made some really great comments before we pressed record in this conversation about I guess you could say a high volume course like the one that you did in Brazil, and something like mine, which is it's designed with a very different intention in mind. And I don't know that it's low volume exactly, but it is.
It's
It's lower.
it's not low because it's only 2 days, right?
Hmm.
2 days. And that's another thing I really like. It was a Friday and a Saturday, so I don't have to
Hmm.
miss work, right? I
Hmm.
had Fridays off already, and then I can just go back to work on Monday.
Hmm.
And it's not very tiring, so we can totally
Hmm.
do it. Go.
Hmm.
So 4 implants is a very good amount for a 2 day course. Absolutely, because sometimes we place only 2 implants per day in
Hmm.
Brazil.
Okay, so it is a similar pace.
It is similar pace, yeah.
What I love about it is the preoperative work that you're doing and that you described, and then the postoperative session too, when you can see what else was done. We've had other attendees who they've gone to the live patient course 3 times now,
Hmm.
and really they've placed as many or more implants than someone who would go to like a course in Mexico where you'll be
Correct.
there, you'll probably be in the clinic in the operatory from Tuesday through Saturday for example, or
Mhm.
maybe Tuesday through Friday, and you'll go, they're usually long days, and you'll probably come away from that placing 12, 15, something like that. And that's just about exactly what people are placing at this course across three of them, comparable costs. But I think you come away with, maybe we could say, your hands and your brain a little more calibrated.
Zero calibrated. That's
Mm,
the biggest difference.
mhm,
And
mhm,
they were all very happy at the end.
mhm, mhm.
We were like all at the same level too. Just really
Yeah.
understanding what we're doing.
Yeah, I think that is just, it's worth a lot. Um, I would love to learn a little bit more about your professional background. I didn't kind of We just kind of moved into that while speaking, but can you tell me, just, I think you went to you did a residency in New York, I know that, but where are you from and where'd you go to school, and what's your professional story?
Yeah, of course. I graduated from the University of Montreal in Canada, 2017, and then went for residency in New York City. That was in the Bronx for a year over there. So that was quite hectic, interesting experience.
Mm,
uh, but it was very very helpful. And then I just had good opportunities to keep learning. I went
mhm,
to was in this Wisconsin. I was spent a year over there, worked a year, and then I moved to Chicago, where I worked there a year and a half because I loved Chicago. It's a beautiful
mhm,
city,
mhm,
and then I just wanted to move closer to home and just find a good opportunity in Plattsburgh, New York, which is like an hour, a little bit over an hour away from Montreal, which is my
uh,
hometown,
uh,
and then worked there a couple of years. And I recently relocated to Vermont, um, in Newport. But when I see all my the different jobs that I had, I learned different things, and implantology was something I kind of wanted to leave to the end.
mm,
And when I was a lot more comfortable, I didn't want to jump into that right away. I don't know why. I saw some people, they graduated last year during their course, and they're already starting placing implants, which is quite amazing.
yeah,
I
yeah,
think I've waited too long. 6 years is a lot of time.
mhm,
I would say 5 years because I took the course last year in Brazil. And then
uh-huh,
slowly started placing implants, and I felt like I was missing a little bit of live patient experience just to become
uh-huh,
more and more confident to be able to diagnose and be like, okay, this is a case I can take, I can do.
yeah,
This is not the complicated case.
mhm,
And then I was just
mm,
searching online, trying to find something that won't take me a whole week or maybe a week and a half travel, take time off from the office, and not too expensive. I also didn't want to spend another 10, 15 grand for another course. And so
mhm,
that was just the perfect opportunity. And then I saw also there's the all the CBCT reading, and which was
yeah.
very, very, I think that made all the difference.
Yes, my aim is to kind of create a scaffolding, kind of a conceptual scaffolding for implantology, where you get a formal introduction to the discipline,
Mm-hmm.
and then you move through that, and then you get into a systematic way of placing implants that will apply really across the board. Yeah, and
Yeah.
then, because when you go to these courses, how do you plug what you learn into that scaffolding? Or when you read an article, or you see just a piece of CE, if you go to the ICOI meeting, for example, um,
Mm,
you're going to get so much great information. But if you can't contextualize it and figure out how
yeah.
to put it in your own workflow, it can be tough. So that's part of my aim, is to kind of create that scaffolding. But
Yeah.
well, that's awesome. Thanks for telling me your story. I love the angle that you're coming at, having had experience with guided before, and it was a GPR in the Bronx that you did, wasn't it?
Yeah, it was a GPR, yeah. But we just restored the implants, but we didn't place any
Hmm.
over there.
Hmm.
Yeah.
I see. I see. Well, how would you be all right with looking at some of the cases that you did? Actually, all the cases. I should say some pictures of all the cases that you did a few weeks ago.
Sure. Yeah.
All right, let's have a little fun. And let's see, where's my pointer? There it is. And I'll screen share and let's take a look at some of these cases. And I'm just wondering, could you talk us through these cases a little bit? By the way,
Hmm.
it's kind of fun, I think, to see this picture. This is Dr. Spears, and I think we ended on this. I think this was him, but you can just see those lined up. The distances are really nice. Looks like a guided case. Yeah. So I grayed out the patient names. So hopefully this will still jog your memory. Can you tell me a little bit about this patient in this case, or do you want some more prompts?
I don't know. I think I remember that patient was missing his two first molars, right and left side,
Hmm.
and he just wanted he wanted to have them replaced,
Hmm.
and so that was actually a very good case because it's placing one on one side and then the exact same one on the other side on
Hmm.
the same patient.
Hmm.
It's like your hands are ready and inside are ready. And so I was able to play the first one. Took a little bit more time, obviously, because it was the first one freehand.
Hmm.
But then all of a sudden, doing the second one was a lot faster, a lot quicker. The bone was very, it was just a very good case, an easy case to start with, from what I
Yeah,
can
nice
remember.
width, and it didn't require any uh, particularly careful maneuvering
Yeah,
as far as bone width or density. Yeah, yeah, yeah. It was great that you could get two reps of the same thing. Let's see.
exactly. The
Here's
feet were pretty parallel too.
mm-hmm,
So,
mm-hmm. You made a slight apical correction
mhm,
from the picture we're seeing with the paralleling pin. I remember that.
yeah.
And from your, that might have been your final osteotomy
The last,
for
yeah, the
the,
second extra.
I think that's kind of at a provisional depth. But here's your final placement on this
Yeah,
right side.
yep,
And it's beautiful. Well done.
yeah. Thank you. It is beautiful.
Yeah, it really is. This is a Blue Sky Bio implant, Biomax. Looks like it's probably a 4.3 by 11.5. And it's,
Possible that I remember.
mhm. Yeah, I bet that's right. Same on the left side. And I've got a picture here too of you placing the healing abutment as opposed to a cover screw. Can you
Mhm.
speak to that decision, why you went in that direction?
Yeah, because we had good primary stability. That's first of all, very good primary stability.
Hmm.
Patient wasn't a smoker or didn't had any heart risks.
Hmm.
So I felt like it will save a lot of surgery to the patient
Hmm.
just to go ahead and put a healing abutment.
Hmm. Yeah, and you did the same on the left side, I think, didn't you? Yeah,
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 yeah.
exactly.
Those will serve him well. I saw him just recently
Oh,
for a post-op, and I removed sutures, and he was just so happy.
good, good. It was
Yeah,
a
you glad to know that?
yeah. I'm very glad to know that.
He reported no pain, and his tissues just look pink and healthy and happy. Because sometimes when you close around a healing abutment, you might not get perfect primary closure at the mesial and at the distal of it. It can be a little, there can be some secondary intention healing going on there. And you kind of wonder sometimes, I think, or you might have some redundant tissue and you wonder how it's all going to kind of settle and shape up. And I took pictures for you actually, but I forgot to put them on
Oh,
here.
oh, it's okay.
Yeah, sorry, but he fared really well. I don't think I have any clinical pictures of the left side, but your flap too. Now, you told us about your time in Brazil and this. your experience thus far with guided surgery, which is so cool, by the way. I've done this too. Having a guide where location, angulation, and depth are determined by the guide, and
Mhm.
there are services from labs and others. I've used True Abutment, for example. They do a really beautiful job of this, where you can do a fully guided case, and it's super fun. But what was your experience with flapping prior to the course, and what was your comfort level with accessing the alveolar ridge like this prior to the course? Was it already pretty high?
It was. I think it was. I was okay, but I feel now a lot more comfortable to flap a little bit more and
Hmm.
not worry really,
Hmm.
and to be able to see the bone very well, and
Hmm.
just flapping the course helped a lot for sure.
That's good. It's fair to
Yeah.
say, I think, that the flap that you did on this lower right side is probably even a little bit more extensive than what the retraction shows or what the photo shows. Uh,
Mm,
y- you can tell that your access on the lingual flap is just really nice, and you're seeing the corner on the lingual of the alveolar crest there. But on the buccal, but you're seeing, I remember you could see a bit more than that even on the lingual. And on the buccal, you can see down to the depth of the implant pretty close. So
yeah,
that if anything untoward were to happen during placement, you'd see it happening and could
right.
make necessary corrections. Yeah.
Yeah.
Yeah. Beautiful job. Here's here's the left side. Yeah, here's your cover screw, or excuse me, your healing abutment.
Mm.
Here's your let's see, both of these cases were back to back. This patient too, I met with her at the same in the same evening and removed her sutures. She was one of those who said no pain. I didn't have any pain. Not
Wow.
just low pain, but none. Isn't that cool?
Yeah, I think she had a few too, right? A few implants.
Yes, she
Yeah.
did. Dr. Provost placed implants in her left side,
Yeah.
and her closure included a periosteal release and also a subepithelial connective tissue graft that still had a pedicle attachment to it as it went over. But she reported no pain after that. Isn't that kind of nice to know?
That's really nice to know. That's not painful and
Yeah. Yeah, and here's kind of some of the data that you gathered prior to going into the course, and you learn how to run all the way through this. Well, I think one of the challenges with CBCT is just that there's so much available data. It's one thing to
yeah.
learn how to manipulate those DICOMs in the software of your choice, but then what data points do you need to take into the operatory, and how do you access them, and things like that.
This is
Uh,
something I forgot to talk about actually. That worksheet is just I love it. And I use it all the time now because you gather all the data and you just bring it with you in the operatory. And that's all you need basically.
I am so glad to hear you say that.
Yeah.
Uh, I think that there's kind of a theme here in a way, I think, because are we talking about guided surgery versus freehand? Yeah, in a way, I guess, but not entirely, because it's two different modes, and kind of like
Mhm.
with CBC treatment planning, CBCT, it's so high tech. This piece of paper is so low tech. So there's kind of it's I think that both modes can be so helpful. It's so great to have access to all the high-tech stuff that's in implantology, and sometimes these fully guided approaches I think are just wonderful. I love doing them, but I also think that they are an advanced procedure that um, it might not seem like an advanced procedure, but I think it is. But it's somewhat similar here. Here's the meeting point between a high technology mode with the CBCT software and kind of a low technology mode with this worksheet. But they
Mhm.
work very well together. There's a lot of years and a lot of thought behind this particular sheet. I'm glad you like it.
Yeah.
Let's see. So your plan here, you can tell you had adequate width. You had a very normal mesiodistal span with this case. You had really nice bone density at the crest, and your height allowed you to place a 5x10 implant or maybe a 4 3x10. And here is your paralleling pin picture. And if the cone cut leaves a little bit of information out, but it looks like not much is needed by way of correction here.
Mm-hmm.
But I think you did mesialize a little bit, uh, if I
Yes.
remember
Yeah.
correctly. Do you remember if you
A little
did?
bit. A little bit.
Hmm. And that's something I hope you liked that too, because hey, it's not uncommon to make a correction after your paralleling pin radiograph. I
Mm-hmm.
had a case today where I made pretty dramatic corrections after I took that radiograph. So that's just kind of part of the game.
Yeah.
But look at your placement. Look at how gorgeous that is.
Yeah. Thank you.
Yeah, you're welcome. And once again, you know, uh, from doing the case, and in fact, think I have a picture that shows this too. Yeah, you are going to have forces that are directed right down the center of that implant. You're going to get axial loading. You know you are, and you know that you're going to get a screw channel that goes right up through the occlusal. We are doing restoratively driven implantology here, and you're
Mhm.
putting it on display. Yeah, well done. This one was fun, and I got to say, this patient, I don't know if you got to get a taste of his full personality. Did you?
Yes, I did. Yeah, I know him very well now, I can say.
Okay. Uh,
Yeah.
he was so complimentary towards you at the post-op,
Oh,
and
really?
yeah, he was, and he wanted me to relay his thanks to you.
Oh,
Uh, yeah, so I hope that brings you joy.
it
It's
does.
a he's kind of a character, and he's really fun, but he healed great. He's excited to do he has some other needs that are a little more advanced.
Okay.
So I think I'll probably see him and do some GBR. Might even need some sinus lifting. I don't remember.
Mm.
But you threaded the needle really well here because his restorative space was a little more limited.
Correct. It was very small. That was very interesting, actually. But it was my fourth implant, and I think I did that. It took me less than an hour. It was placed within an hour, which is quite amazing to do
Yeah,
this really that quick.
all these reps really helped, I think. And I think that this is one that in the treatment planning session, there was some worry or some concern about the tightness of this space. And we may have to do some enamelplasty here.
Yeah.
But well, one thing that's kind of becomes intuitive with free-handed placement too, if we go back to this picture, is that look, if your driver looked that good when you placed it, then you know later that your impression coping is going to look just like that. It's going to look really good. And when you come back to this case and you see this marginal ridge right here and its
Yeah.
relationship to the healing abutment, well, you didn't have to do anything uh, creative or fiddly, if that's a word. You didn't have to fiddle that much to get that healing abutment in place. You weren't bumping into that marginal ridge,
Yeah.
um, despite kind of what it looks like on this two-dimensional radiograph. So you know that if your surgical components went in that easily, your restorative components are going to fit equally easy. Now, it may be that we'll want to do some plasty here, and that's fine, but it's going to be very doable.
Yeah. We wanted to stay parallel to the second premolar because the other one was tilted. The second molar was tilted,
Hmm.
and we just felt there was not a good occlusal plane.
Hmm. And that was a very deliberate decision, right? Because we talked
Mhm.
that through in the treatment planning session.
Right.
And look at your parallelism; it's just gorgeous. And then here's this clinical photography again, that from this particular angle you can see, oh yeah, if the
Yeah.
surgical components fit that well, then I know that the restorative components are going to fit well too.
Correct.
Yeah, well, you did this on the kind of a foundation of already having a good knowledge of anatomy, having a certain level of comfort with surgical access, having the training that you need with the cone beam software. So all these things are additive, and is it easy? Well, yeah, I think it's easy, but I don't know if that's the right way to portray cases like the ones that you did. I think it's easy to fly an airplane too at certain times if you if you're already good at it or you know how. But you have to be very systematic about this and make sure that you know what your relationship is to any anatomical hazards and really execute a placement that is, as we've kind of said tonight, restoratively driven.
Hmm.
So you did a beautiful job of that. Well done, Dr.
Thank you.
Mohammedi.
Appreciate it.
You're
I think
so
it
welcome.
becomes easy when we are well trained.
Hmm. Hmm.
Yeah.
And I
When
think
we're
that's the word too, is
prepared to
training.
it's the training. It's the
Hmm.
behind the scene. What's for what we're doing before the surgery that
Hmm.
made all the difference. We don't just arrive there and here's what you need to do. Here's the
Hmm.
drill you need to use. No, this is how we do it.
Hmm.
How we will do it. We prepare every single step. So that made all the difference.
I'm really tickled to hear that you've been using the worksheet and that you're looking at these cases now in your own office through kind of a new lens. That really makes my
Mhm.
day. Well, thank you so much, Selma. You are so fun to talk to. Um, I've really enjoyed just learning a little bit more about your story and what you're doing professionally, and having the course was a real joy. Any final words?
It was the same for me, Dr. Hillam. You are so knowledgeable and so thorough in your work. We can tell that you really have a lot of experience. I was actually very glad that you're a general dentist. To do better than a lot of specialists.
Thank
And
you. That's
so,
kind words.
oh, yeah. So I think that was really great. Thank you very
Good.
much.
You're so welcome. You're always able to come back. Of course, the format of the live patient treatment course is the same every time, and if you want more of the same, you can do that. Or when you're ready to engage with the sinus, you can do that. As we're screening patients, we can do some crestals or some lateral windows. All of those things are possible in the future once you're ready.
Yeah, that would be really great. Just make us really comfortable
Mm.
and we'll just feel very, very confident. And it's easy for us just to proceed. So thank you
Good.
very much.
You are so welcome. Thanks for meeting with me tonight. I'll close this episode out on a high and really appreciate talking to you tonight, Selma.
Likewise. It was a real pleasure. Bye bye.
Bye bye. Thanks a lot.
Take care.